Look, the first question, we haven't, you can also add both questions, so I will just go in the order that they've been formulated. Comes from Susan Wojciechowski and reads, do you have any experience on the use of CBD products to address sleep disturbances in clients with PTSD? There would appear to be considerable promise with these medications and few unwanted effects. Either of you happy to have a stab at this?
Yeah. Julie, would you like to go first?
For me, it's quite short. I mean, in non-refugee populations, definitely CBD oil with THC, without THC have shown to improve sleep, especially in clients with PTSD symptoms. So I don't know the data out there, but it has shown to improve sleep quality. However, it have not done, there's no research done, from my knowledge, in the refugee population.
We didn't use CBD and we don't use CBD in our work at STARTS, but I've mentored someone who is working with clients with complex trauma, developmental traumas mostly, and she was using CBD oil in her practice. She was referring clients to us for EEG assessment, and then we could see the impact then of CBD oil. So we were looking at EEG before and after. And for some clients, it did work well, and we could see improvement in sleep and also reduction in anxiety, but there were clients who didn't respond well to CBD oil. And for example, clients that I presented today with temporal lobe epilepsy, and many of our clients who have temporal lobe instabilities. And what we can see is many of clients with complex presentation have unstable temporal lobes. They don't respond well to CBD oil. And we could see increase in seizures, for example, and increase in temporal lobe instabilities. And then apparently the ideation is one of the symptoms that we can see as increase with CBD oil, increase in anxiety that is not expected. So it is promising, but it needs to be very carefully administered.
Thank you, Miriam and Julie. Next question is, during counseling, introducing diaphragmatic breathing was introduced to the clients. However, he reported unable to learn to breathe from his stomach. Do we know why this was the case with this very engaging and enthusiastic client?
Yeah, it's frequently, but you see that in many of our clients, diaphragm is really stiff, and they learn over time to breathe from the top of their lungs only. So it's very shallow breathing. So initially, what we need to teach them and show them, and that's what how David worked with his client, to put him in front of a mirror and show him how his breathing pattern looks like. You breathe and you move your shoulders. Your diaphragm is not moving at all. Sometimes it's massaging the middle of stomach, helping as well to release and stretch diaphragm, but definitely getting awareness of breathing through the stomach and how stomach needs to move. With clients who were exposed to sexual abuse, that can be trauma-provoking. And with them, it takes longer time to teach them to breathe, to use deep and slow breathing. With them, we don't focus on stomach and on as much on diaphragm as on slowing down their breath. So there are different reasons why people don't learn or don't know how to breathe using their stomach, but we can definitely show them how to do it, show them what they're doing, and correct their breathing patterns.
So for me, in my clinical practice, I know that even non-refugee populations sometimes overthink the process, breathing from the chest for no stomach. So one of the techniques I learned years ago, I can't really show you because of the way I position my laptop, but the technique that I use is I ask them to actually empty out their air in the stomach. So what you do is you put your hands on your stomach and you push it in and you let out and open your mouth and you will let out all the air. Give you an example. Okay, it's not very glam, but if you put your hand in your stomach and you push it upward, in and up, and open your mouth and let out the air. You do it with them, show them first. For example, it's like, what happened is when you take the first breath, it went to a diaphragm. Then it's like, then you tell them, see, it works. Then you breathe, because the first air will go to diaphragm because you emptied it out. Then you slowly then coach them. Good, breathe it out and you empty it again, breathe it in, it goes directly to the stomach or to the diaphragm. So that's the technique I use. Yeah.
Thank you both. I'm going to go to the next question that we have that's been upvoted, which is, Julie, in your study, how long had the participants been in Australia? And when did you do the first research? And then how much later was T2?
So thank you, Peter. So participant in the community sample is in the community sample. That one, because I did it in 2018. So the average, they've been around for about a year and a half, 20 months. But the SD is about 10 months. So some of them have arrived, within 10 months. Some of them have arrived for about 2.5 years. What was the question again? In
your study, how long had the participants been in Australia? And the
so about a year and a half.
Time between the two, T1 and T2.
Yeah, so 12 months. 12 months follow-up. So most of them have arrived about 20 months, and then a follow-up, of course, about 32 months later. Yeah.
Thank you. The next question just been uploaded is, Mariana, could you expand more on the treatments for the sleep disturbance? And I suppose there's been a lot of things that have been used on the sleep disturbance. So that's maybe one that can be addressed by you both, You were mentioning before, Julie, that there's been we have very little research on the treatment of a sleep disturbance in refugees. So if you can tell us about the different things, the things that maybe have not been researched yet, where we should direct our research efforts.
So in 2017 meta-analysis, there's only 4 studies. One is on music therapy, but the number of the participants is really small. It's like less than 20. So it's never been reproduced again. And then the other 3 was on medication. So, and then in 2017, Sandals and the team did a big research looking at add-on the antidepressant that's very sedating, plus nightmare therapy for nightmare. Unfortunately, it doesn't show to be improved as compared to treatment as usual. So those are the only one that actually using like psychotherapy. And whereas in the other mainstream therapy, cognitive behavior therapy for insomnia, CBTI, is the gold standard to treat sleep disturbance. However, it has not been studied. It's my dream to actually conduct that studies. So yeah, that's from my research and understanding from the literature.
Yes, from our clinical practice, first of all, we need to make a really good assessment of what type of sleep disturbances we are talking about.
Yeah.
And we often see with our clients that apart from difficulties falling asleep and nightmares, they might have also sleep apnea. They might have other different types of sleep disorders. So good understanding and good assessment is number one. Interventions that we use, one of them is neurofeedback. Neurofeedback, there is a research behind sleep enhancement and neurofeedback. And neurofeedback initially was used to stabilize sleep. So it's a great intervention. With this client, we didn't, actually for this client, neurofeedback was used to stabilize sleep, but actually much more than that. But often clients are sent to our clinic if they are unable through CBT or other interventions to improve sleep, and neurofeedback can be quite effective. But also what we can see, exercises, changes in daily routine. Sleep hygiene is very important. It's a diet that you have. If you drink 10 Cokes a day, and we have clients sometimes 10 teas a day.
Yeah.
Caffeinated drinks, of course, they will have difficulty falling asleep, and also they will have disturbed sleep. Also, clients that take alcohol to drink because that is helping them to fall asleep, then they have very shallow and poor quality of sleep. So we need to check all of this. It's not one intervention that works with sleep problems. It's finding, first of all, what are the causes of sleep disturbances, and then addressing them through different interventions.
100%. I would like to add on. I mean, Mariana, when you mentioned about, yes, I talk about sleep disturbance in a very general umbrella. It's about quality, quantity, difficulty falling asleep, staying asleep. But that's the thing, you need to do a proper assessment to understand, is it sleep apnea? Because sleep apnea, you don't do CBT. You need to get a, CPAP, for example, and the different sleep disorder. It's very treatment, but this is if we're talking about quality of sleep and quantity of sleep, yes, CBTI is the gold standard. And the other thing is, Mariana, when you start talking about neurofeedback, it's not something that I'm very aware of. It's about stabilizing. And in my research, you saw pre-sleep arousal is one that really predict. And I'm thinking there's a connection there, isn't it? There's something about them being aroused, whether cognitively or somatically. That is something that can't predict or can also disturb the mental health and the quality of sleep. It's fascinating, but
absolutely, yes. And we can look at different types of anxiety, or is it physiological arousal, relaxation exercises, again, changes in diet, neurofeedback can help to reduce the arousal. Or is it more cognitive? Are there worries? Is that what is keeping our clients awake? Then different type of cognitive behavioral strategies can help.
Yeah, and in the qualitative study from my second study, it shows that out of the 4 themes, so there is somatic and there are a lot of cognition. So there's something there that I think more research. I've said that many times, but more research is needed to look at it. There's something there about pre-sleep arousal, whether cognitively or somatically. Yeah.
Thank you. And you just touched on another question that I came up, which was precisely on this, whether you'd be able to speak a bit more about your research findings, particularly in terms of pre-sleep arousal.
So pre-sleep arousal, there's 2 components. One is cognitively, like you can't shut your mind off. You just, mind is really busy when you're going to bed. And somatically, you just, hyper aroused, meaning you just can't settle. You're very fidgety and stuff like that. So out of when I was looking for like conceptual model, there's something about pre-sleep arousal. There's nothing that been studied before in the refugee field, but it's just those hunch that I added in, but it's still quite vague, meaning what is it about pre-sleep arousal? Like from Mariana presentation, is it activation of the nervous system? Like it can be so many things. So unfortunately, mine is just 16 questions in pre-sleep arousal, but it's very promising because it's the one that predict more than insomnia severity. It's the one actually also can predict the mental health long term. Yeah.
Thank you. We probably got time for one more question. It comes from Fatana Rahimi. Some of the well-known trauma experts are against medication in the treatment of sleep disturbances. What is your opinion on this? And this can, I think, you can both provide us your opinion.
Yeah, from the sleep literature, they talk about how when you use medication to treat sleep, it's very temporary, meaning you don't really learn the behavior and changing the way you think about sleep. So it's very temporary. And when they stop using the medication, the sleep just gone worse. Whereas, of course, with CBTI, it's about learning the behavior and changing the way you think, and that have shown to have long-term. In fact, they said the longer they do the follow-up, the better the improvement. Like it's out there. So of course, for some people who study sleep, whether it's sleep physician, they will actually against medication. But what we can see in terms of a GP clinic, whether for refugee or regular clinic, they just prescribe because it's easy. You need sleep. There's no psychologist. There's not enough psychologists, and not enough psychologists actually trained in CBTI, to be honest. So they just give medication. So it's almost like there's no other choice. But if you talk to sleep physician, they usually will against sleep medication.
Miriana, anything you want to add on this?
Definitely, sleep medication is not addressing underlying causes of sleep difficulties. It's trying to deal with the symptoms, but then it's creating other symptoms as well. From what we can clinically see is that clients on oral sleep medication are not getting good quality of sleep. And over time, they can get dependent of sleep medication, and they need to use more and more sleep medication. That is then also impacting on their brain and nervous system functioning. So definitely, as a clinician, that wouldn't be my treatment of choice for insomnia or other types of sleep difficulties.
Mm. Okay, look, I'm just going to ask you one last thought on this question. It comes from Ash Hosseini. And reads, the recent research has revealed that for reducing stress and arousal, we need to reduce oxygen in the brain by applying exhale breathing. What do you think about this for helping with sleep?
Heart rate variability biofeedback is one of the interventions that we use at STARTS. And through slowing down your breath and deepening your breath, you're getting increase in oxygen to your brain. So definitely by changing the level of carbon dioxide and oxygen and normalizing, you can, to a certain degree, you also then improve brain functioning. So heart rate variability, breathing exercises, and exercises in general are good and not expensive and quite effective interventions.
I've not heard about reducing oxygen level in the brain. For sure, exhaling breathing is part of the deep breathing. It's really about slowing down when you exhale. So when you have deep breathing, of course, your body relaxes, then your brainwave will, slow down, and of course that can improve with sleep. However, to be more specific, reducing oxygen in the brain, I have no idea that will help.
Yeah, no, I hadn't heard. That's why, this just came up. Yeah, I thought it was interesting. Maybe you would know about this.
I'll check with Ash. I know Ash, so we used to work in foundation health.
Maybe something that has come up. But
definitely not through diaphragmatic breathing. That's not what is happening. Stopping your breath, yes, but not through
reducing oxygen.
Yes. Yeah. Look, this has been fascinating. There's many other things that we could touch on sleep, and I'm sure that it won't be the last time that we look at sleep in these clinical masterclasses. So thank you so much. You've been wonderful, and it's been such a good clinical masterclass to close, the cycle this year. So thank you. It's a big, I'm sure, applause from all of us. And certainly, Julie, we'd love to hear more about your ideas. So send us an email in terms of, what we should be prioritizing in terms of research. I think that this is an area where probably we need to get more data, particularly since so many of our clients, suffer from sleep disturbances. So any ideas in that regard, would be
we'll love to
welcome.
We'll love to chat about that. Yeah.
Okay. Excellent. I'll hold you to that. And thanks, everyone. I look forward to see you all next year. We'll have another 5 fantastic clinical masterclasses, and we will be sending information about when they're being held and what the topics are going to be. So have a great Christmas, a great beginning of the new year, and look forward to see you. All the best.